tonight. But we're going to go through a whirlwind of syncope, vertigo, and abscess because who doesn't love a good abscess? I know I do, Alan. I'm sure you've seen a lot in the emergency setting. They are just so satisfying. So, without further ado, let's get into it. So, approach to syncope. It can feel, I don't know about you, Alan, but somewhat nebulous at times. We don't want to overtest, we don't want to undertest. We're worried about cardiac causes. What's your sort of, I guess, initial approach or thinking to syncope if someone comes in to faint?
I like to call syncope like the great mimic of everything, you know? And if there's any presenting concern that should make your butt cheeks go like this, it's usually syncope because as you alluded to, Vicky, the differential is wide as can be. It's probably larger than the waistband of my forthcoming Christmas pants. You know, there's just a lot of badness can be associated with it. And, while emergency medicine is its own kind of field of knowledge and expertise, it really is scattered throughout all specialties. So it's kind of like you kind of got to be familiar with all the badness that's associated with syncope. So I guess how I approach syncope and how I was just trained in my heuristic mindset is I always think about all the bad stuff first.
Mhm.
Now, I know in school they teach things like, what's it, vitamins, or there's like another thing for differentials. I don't know, man. I am the most like moderately competent person. I can't remember any of those acronyms, even though I'm forced to teach them.
The mnemonic.
I basically go based on what I need to exclude for badness first. And
Mhm.
typically those are those bad things like is it cardiogenic? I look for is it coming from upstairs in the dome? Is
Mhm.
it coming reflex? Are there other mimics that people will say, well, I fainted or it was a syncope if you're given that history from a triage nurse or a medic or MOA or something, but when in fact it was hypoglycemia or a subtle stroke. So it's kind of like, so that's kind of how I approach it to first is, are they all the big, bad, scary things? Unfortunately, for the most part, maybe I've been lucky in my time, Vicky. I don't know. For the most part, often the syncope won't be the big, bad, scary things, even though you go looking for them. But often you just have to accept that the etiology you probably just won't know. So in that circumstance, I usually go quite systematic, and I usually kind of organize them into kind of four broad categories. The first much my approach is, I think, cardiogenic, particularly for older folks. But I also don't underestimate young, healthy women, because if there's going to be something that happens, it's always to young, healthy women. Second one is I think of is it reflexive? So is it neurally mediated? Stuff like vasovagal, situational, that type of thing. Third one is I start looking a little bit for orthostatic hypotension. That's a little bit of a tricky one, but that's when I start thinking about that. And then, of course, the non-syncope mimics. That's kind of how I organize my thought process.
And I love how it's still a diagnostic framework. You're not just rattling off random things, but kind of breaking them down, almost like a systems approach, right? Cardiogenic, etc. So, I mean, I threw a case out here just to sort of guide us through. So, yeah, an older male. So, again, prevalence of badness might be a bit higher. We think of cardiac or stuff up in the dome, like you mentioned. Had an LOC for a minute. So, differential, we have very similar ones, right? I like to think of two buckets. Is it cardiac syncope or is it non-cardiac syncope? And that cardiac bucket, breaking it down further, is it an arrhythmia, right? Bradycardia, tachycardia, and irregular rhythm, or is it something structural or something cardiopulmonary like a PE, right? Those syncope mimics, like you mentioned. And then in that non-cardiac bucket, it's wide, like you said, which makes it so difficult to pare down sometimes. But thankfully, some patients do present with that prototypical vasovagal, and we're really happy about those. But it could be carotid sinus syncope, situational, orthostatic intolerance, like you mentioned. Is this person dehydrated? Do they have POTS, Parkinson disease, medication side effects? So I think, again, just really highlighting it's important to have that diagnostic framework so that you can cue your memory and remembering all these different illness scripts. So at least you kind of know how to perform that history and physical exam, right? So from there, do you have somewhat of a structured approach in how you're going to perform that history and physical on a person with syncope.
Yeah, so my approach is typically is always go in with a healthy dose of skepticism if you've been privileged or lucky to have information beforehand. I have an heuristic, Vicky. It's trust everyone, verify everything. So I always keep an open mind, and I always say being skeptical is a good thing. Being skeptical means that you're open to new information and you're open to change. So I always come in with a skeptical approach. With respect to my assessment approach, if they don't need resuscitation or something to that effect, which is kind of actually what I did a couple of weeks ago, but if they don't need resuscitative stuff, I basically just launch into my typical H&P. But, without boring you of all the, with an OSCE style.
Yeah, yeah.
Although I don't think the rest of Canada has an OSCE. I think British Columbia was the only one up until recently.
Yeah.
Um, Without boring you with all those details about that, like, what questions I would ask, is it okay if I just focus on like what I would specifically look for in this case?
Please do. Yeah, and I think we're probably in alignment with the big bad stuff, right?
Cool. So how I would approach the assessment is first confirm it is actually syncope. Like, was it actually cardiogenic syncope? So things I want to know that I will hammer the line of questioning on, and then ask differently at different points is, was there a transient loss of consciousness with full recovery? And when I say a loss of consciousness, if I'm looking for cardiogenic, I'm looking, is it lights out? Not a, oh, I'm going through I felt warm, then I got tunnel vision, and then out. And it's not, I felt like numbness and then out. I'm talking lights out, blackout, with rapid recovery afterwards. One of the things I want to know afterwards is if I was lucky enough to have a glucose, was it hypoglycemia? Like how many times I've been burned, it was hypoglycemia, right? And then other points of the history I really, really want to know are there any histories of epilepsy, seizure, intoxication, psychogenic events, any type of precipitant that I want to know? Again, I'm going back to young women here, but just go with me for a moment here, Vicky. The amount of times I've seen syncope in young, healthy women, and it turned out to be hypovolemia because of menses or abnormal uterine bleeding or an ectopic.
Mm.
I can't count how many times, so I always have a degree of suspicion for that subset of population. When I'm examining someone, and I'm a huge EBM dork, I guess you could say. So I really like knowing the data behind my physical exams and like why I do them. So, if someone has syncope and I'm trying to exclude a seizure, I usually will look for a tongue bite. Um, I believe the sensitivity is somewhere about 30%, but the specificity is around 95 and up. So, just so we can, for a quick refresher, sensitivity with broad strokes typically means you can rule out a condition, and specificity means you can rule in something. So, in this case, the clinical question is this tongue bite a seizure? So, you can't really rule it out with a tongue bite. But you can rule it in. So, in this case, if I thought it was a seizure and they had a tongue bite, I could probably rule it in. But, without further information in the case, can't rule anything out at this point. The other thing I kind of want to know is about was there any like head turning or posturing if that data was available to me? I believe the sensitivity and specificity of it is somewhere north of 80 to 90%. I think if I recall, the positive likelihood ratios were something like 9 or something. So it's probably good enough to give you some info. So for those of us that need a bit of a refresher, likelihood ratios is kind of like, you take your pre-test probability of a certain disease or condition, and then you apply the data to it. So the test. So in this case, it would be like, turning your head or posturing, and then it would be like the likelihood of it with your post-test probability. Should probably have drawn like a whiteboard fig and nomogram here or something. Hey, thank you.
Love it. Thank you.
Um, so that's typically kind of my approach there. When I target a physical exam, oh, sorry, before I get in there, I really hammer home the prodrome, like really, really, really hammer home the prodrome, because that's going to give you the information. Again, that nausea, the warmth, that type of stuff, that's unlikely to be cardiogenic syncope. That's almost that's more in keeping with a neurally mediated, so usually a vagal event. I also want to know, like, hey man, what like what were you doing at the time? I got a good one for you here, Vicky. I had a very healthy, wonderful human being. She was a professional athlete. She had syncope, fainted on the soccer field. So she presented and undifferentiated. She was like, oh, I think I was just dehydrated. It's hot, yada, yada, yada. I decided to put the POCUS on her
Mm.
to look for a structural cause. And I'm not doing like, your husband, Vicky's like type of POCUS. So just so you all know, Vicky's husband is Ross Prager, and the guy's like if I'm an ultrasound scoundrel, that guy's like a sonophile. And anyway, so I'm not doing all of his like TR jets and all that stuff. I'm just looking for like, hey man, is the heart moving or not? So I put the POCUS on her and I was like, huh, your left ventricle is kind of closing off your LVOT and it looks really big. Um, I turned out she had HOCM, so
Oh,
hypertrophic
okay.
cardiac obstructive cardiac cardiomyopathy. For physical, I'm not convinced if I like orthostatic vitals. I looked at the data behind it. It's kind of like flip of a coin. I can't rule anything out with it. I can't really rule anything in, and there are too many confounding factors per se. But I mean, if I have a colleague who can perform them, maybe I'll get them. I think there was some data in evidence-based medicine, evidence-based diagnosis by, I think it was Lewis. Say something like a systolic drop of 20 or more is probably consistent with hypotension. So maybe give you some info.
Gotcha.
But at the end of the day, my targeted physical, is probably neural. It's going to be cardiogenic, cardiopulmonary. I'll listen for murmurs and all that stuff. But Vicky, can I just be honest here? Murmurs. I remember like what's that mnemonic, Mr. Ass and Miss Ard.
Look for
Like I
mitral valve
remember those
stenosis and all that
mnemonics.
stuff. Yeah, yeah.
I think I can hear something. I think my stethoscope is probably a little bit older. These days, I rely on POCUS to give me that info. So
Yeah,
what I would
beautiful.
do with POCUS is interrogate the valves to look for valvulopathy. And I'm not talking like I quantify the exact volume going through. I'm just trying to see if there's any obvious regurgitation or any failure of the leaflets, or if they're not closing properly. I look at the LV contractility. I look to see how dilated the RV is. You could probably sense here that POCUS gives me quite a lot of information with respect to the cardiovascular exam there.
Yeah, so top takeaway is out with the stethoscope, in with POCUS is what I'm hearing.
I think they complement each other. It's kind of like avocado. And so if like if the stethoscope is like avocado, it's like, and POCUS is like spiced, or sorry, what's that? Smoked paprika. Have you ever put the two together?
Never.
Oh, they're even better than salt and avocado. It's like
Okay.
that. They
Yeah.
go well together.
I love that. And I think, yeah, I'm not the biggest fan of mnemonics either, but sometimes they will kind of cue my memory. So again, looking for the bad stuff, right? You can use the five P's. Again, prodrome, if there is none, big red flag. Exercise, big red flag. If they fainted while lying down, something's evidently wrong. Looking for those post-event symptoms. And then LMP, like you said, there's been a few times person presents with syncope and either, it's heavy menstrual bleeding, anemia, or they're pregnant. So really keeping that in the back of our minds for younger females of childbearing age. So thanks for sharing those pearls. Big question, because coming from a primary care setting, if a patient's coming to me outpatient setting, they fainted 3 days ago, they're healthy, it sounds vasovagal. I'll be honest, I won't always order an ECG, but now I'm questioning, Canadian Cardiovascular Society, American College Cardiology, they all recommend ordering an ECG for all with the HNP. But I think always following guidelines with a grain of salt, using your clinical gestalt and experience. What's your kind of takeaway from that, from the emerge setting, but then also the family practice setting?
Yeah, and again, EM is just everywhere. So it's kind of like the best first 10 minutes of every specialty. So I would say is that I always smile when I see guidelines from very dedicated cardiovascular societies. I think they have I think, they're obviously they're the experts, the consultants. They have their time and place. I also think that the vast majority of the time they're not seeing the undifferentiated syncope. They're seeing them curated often once say someone in family medicine, emerge, internal medicine has almost like excluded and packaged it up a little bit. With that being said, there are different circumstances. So I always say is, what was that data, informing that recommendation? Or was it like, kind of an old boys club in a room type of thing? For me personally, a lot of it depends on the pretest probability if something is indeed cardiogenic.
Mhm.
I would probably say my testing threshold, though, Vicky, for ECG varies. I wish there could be like some sort of like age cutoff or something like, the D-dimer age cutoff, but I don't have any data that I know of. I usually go based off of Gestalt.
Mhm.
So I would say is probably not ECG for all with an asterisk and say high risk. Anybody that makes me, anybody that doesn't fit the pattern for a very clear non-cardiogenic
Yeah.
syncope, I'll arrange it. Yeah, it's such a cheap, easy test,
Mhm.
non-invasive. You can get a lot of info.
Exactly. And I think, yeah, just always weighing that pretest probability. If our pretest probability of a vasovagal syncope in a very healthy person, no risk factors, is very high, then there's always running the risk of a false positive test on an ECG. It may show an old infarct on a 20-year-old when that doesn't really make sense clinically. So I'm always trying to weigh that in my mind.
That's early repoll, Vicky. It's early repoll, right?
Yes,
And then it
exactly.
turns out, oh, it was pericarditis. They were sick with something. You're like, oh gosh, what do I do now?
Yeah,
Yeah.
exactly. What do I do now? Love it. And then that kind of follows a similar thread, which you've already gotten into, but in terms of risk stratification, so understanding our low risk features versus our high risk features. So let's say with our patient, our case tonight, there was no prodrome and there was signs of conduction disease on that ECG, so a bivesicular block.
Okay.
So a block below that AV node. So if you see a pattern like this on ECG, what are you thinking? What's causing it? What are your next steps?
How old was this guy again?
So in his 50s.
50s? Okay. Um, I think that there's enough pretest probability now for badness I wouldn't say badness. There's enough for us to go looking. So
Mhm.
as the eternal generalist, and at this point, if I saw a bifascicular block, and assuming they look well now after the syncope event, I wouldn't rush and request a TVP like a transvenous pacer or anything. But certainly, I would work them up for cardiac disease and send them out for consideration of whether a cards wants pacing or maybe ICD, or maybe they want to send them out to EP or something to that effect. But at this point, I would work them out just because there's enough unpredictability with bifascicular blocks.
Exactly. And there's so many different underlying etiologies, right? Whether it's coronary artery disease, previous MI, structural heart disease, hyperkalemia in rare cases. So yeah, it's definitely worthwhile. And then similar to that effect for this case, or maybe people with maybe some more high risk features or even undifferentiated syncope, any other labs that you're throwing at them, sodiums, potassiums, CBCs, troponins, like how do you, and it's not a shotgun approach, right? But how do you kind of, what the emerge sometimes it is because you might not see them again.
Yeah, with respect to labs, assuming that the story was fairly benign-ish and they look well now, the likelihood of labs will likely be normal, or like it'll be just barely above outside of a norm, and it's not really much to act on. If anything, so I put it into kind of two schools of thought. I want the biggest bang for the buck biggest bang for my buck as I can. So I would order some blood work that I would anticipate or predict that a consultant would likely need to help them dispo. So
Mhm.
think like for the outpatient stuff, assuming this is like urgent emerge inpatient stuff, I'd look at like, BNP, maybe CK, all that kind of stuff that they want. With respect to like if this was an acute case, certainly I want to look for K. So potassium is like the big one. Electrolytes is a common one. Renal function, helpful if you have access to a rapid turnaround and monitoring if you're in a merge setting, troponins, of course. However, that's typically to the extent of the blood work that I would arrange. I would send them out for an echo.
Yeah.
And alluding to what you did mention, Vicky, with bifascicular blocks, they are often kind of like the sign of something else happened somewhere we just don't know.
Mhm.
Um, Maybe consideration of a stress test, although where I live now, it's a little bit more ring fenced off. I'm not sure where it is in other jurisdictions.
Mhm. Okay, that's really helpful. Thank you. And then again, right, like this risk stratification tool put out by Canadian Cardiovascular Society, I think within the last few years, like it's been widely validated. And for this gentleman, he's certainly in the moderate to high kind of intermediate risk category. But even in a primary care setting, I might not have that ECG right away, or, so I can't fully tally up these scores. Is this something that's commonly used in emerge settings? Or are you more so relying on your clinical gestalt, right?
Yeah, that's the exciting thing. In fact, it's been subject of debate for many years is when and how do you dispo folks that have had syncope where the diagnosis is unclear, which is the vast majority of cases.
Mm.
Um, I found that folks are using this score more often. It can be helpful. This is certainly in the emerge setting. This was validated in the studied for and validated, among the emerge population. Um, and it was done out of the Ottawa groups. So that you're a bit of a bias. I remember, Vicky, you're from Ottawa, right?
Yes.
So the Ottawa group, the Ottawa EM group is just world renowned for all of the Ottawa rules that you probably apply, but now they're changing it to the Canadian rules. So I find that if there's enough of a decision-making tool to help push you in a certain direction. Certainly, personally, I would use this tool where there was doubt or where there was enough ambiguity, and the diagnosis is equivocal. I have found my colleagues have been using it in those situations.
Super helpful. Yeah, because it's really the intermediate risk folks that,
Yes.
do you keep them like this gentleman, right? Would you just expedite a more of an urgent cardiology referral? Would you keep them in-house longer? More investigations you already alluded to. So you mentioned echo, blood work. What about a Holter in these folks? Like, are
Mhm.
you kind of maybe presenting with palpitations, or you're worried you missed maybe an arrhythmia on ECG? Where do you go from here?
Yeah, absolutely. Holters can be certainly helpful. If it's that, it's the extremes are quite easy, is the
Yeah.
dispo's already arranged. It's that intermediate risk. So certainly, I would base a lot of info, based a lot of my dispo on their overall risk and their history. So if they've had no past medical history, no meds, non-smoker, probably okay to as an like a fairly urgent outpatient referral. If it's the smoker, maybe a family history of early coronary artery disease. If it's folks that we just don't know much information about, it might warrant at least an inpatient referral or at least get them to turn around with a consult within the next 24 to 48 hours. I like how you wrote driving.
It never gets easier. So I hate reporting, driving. I think none of us enjoy it, and it never gets easier. So what's your sort of approach, or maybe some scripts or takeaways that people can learn from you tonight in terms of how you script it, how you communicate it with patients?
Yeah, certainly I can't tell you if my approach is certainly the best, but I can probably tell you it's moderate. And my approach to that is I'm usually quite frank with patients, and I find that the vast majority are quite receptive. And I present the facts. And it's I find that where the advantage of a nurse practitioner is that you have some sort of um, experience in nursing, and often that involves really connecting with patients. I know it's like super airy-fairy and new age, but there's a whole point of that stuff. But I usually just be quite frank and say, look, you passed out. We don't know why. That's probably bad, hey? And I haven't had one person say, "Oh no, it's nothing." They might be a little bit of denial, but you know that they know it's not a great thing. So I
Mhm.
usually pose it as, listen, your safety and your family and your loved ones are your utmost priority. So I'd say is don't drive until we find out what's going on. Yeah, it's gonna suck for your life, but can you imagine what it would be like if you weren't here tomorrow, or if you had a loved one in your vehicle, or if something catastrophic happened to another? So I usually try to connect with them, and 9.8 times out of 10, most folks are okay with that. Whether or not they continue to drive, I'm not entirely sure, but most folks to my face have not said otherwise. Where it would be kind of sketchy would be the 0.2%, where I kind of can't predict what would happen. And in that case, if there, I would bring in, if it's a bit of a cognition, if it's an older adult, then I might pull and restrict it then.
As well. Yeah, exactly. And
Mhm.
I think it's just that messaging of, hey, like, I'm not taking your license away here. I just have that duty to report, I need to legally. And like you said, most patients are understanding. They may be frustrated, they may yell at you, but I think they kind of come away understanding why it's happening. And of course, that goes for reporting drivers where it's undifferentiated. There's been some clear red flags like no prodrome, happened during exercise, history of coronary artery disease, etc., where that syncopal event is more likely to happen again versus vasovagal, very evident, healthy patient. We're not necessarily needing to report those very clear-cut syncope cases where we're not worried about it happening again or unpredictably, I should say. Yeah, that's super
Can I
helpful.
can I share a screen real quick?
Please do.
Oh.
I can see it well enough.
Yeah, okay.
Thank
So the
you.
purple there, the far part of the screen there, that's the purple part is the left side of the heart, and the green is the right side of the heart. This is normal. You can probably see my obnoxiously large mouse cursor because I can't see, but I'm
That's
trying
good.
to point at the mitral valve here.
Yep.
So this is what a normal bedside parasternal long interrogation of the heart should look like. So you can kind of like get an idea of just how clear you can, if you bring in focus, you can see the heart rather
Mhm.
than relying on like, point of maximal tenderness and stuff. I mean, it's all helpful, but I don't know, I like to see stuff.
Yeah.
So just like, that's normal. This is what it looks like as abnormal. So, you can't really see the left ventricle at the mid ventricle very well, but you can kind of see how it's not really squeezing there. So if you compare that with this one, see the difference?
And that was the hypertrophic cardiomyopathy case.
This one's just reduced LV. I was
Oh,
trying to
reduced
find
LV.
a hokum, but I couldn't find one.
Yeah, yeah,
But
yeah.
this would be normal. So you can see how they're probably squeezing out. I don't
Really
know.
squeezing out. Yeah.
Yeah, and then this one, I mean, they're right there. So right there, based on this alone, that would make my decision for dispo.
Yeah.
Yeah.
Yeah, and that, this kind of summarizes, right? No serious medical condition, dispo home, unclear intermediate. We might be doing some expedited referrals for their testing, and then obviously, high pretest probability for cardiac stuff. It's easier because something's bad, they need to be worked up urgently. So what are some, I mean, I wrote some t takeaways, but what are some takeaways that you want folks to kind of really remember for the next time they see a patient with syncope?
Yeah, keep them at like three very high arching heuristics. Number one is the money is in the history. Probably not your test. The money in the bank is the history, especially the trigger. The second one is if there's not an obvious cause of why they had syncope, trust that inner instinct that you should probably go digging a little further and you need to exclude badness. The third one is at least for myself, I associate syncope with the older population. And yeah, and that's kind of a given. You look for a lot of badness because it's more prevalent among them, but don't discount the young, healthy people. Uh, and check a beta for young, healthy women.
Yes. Yeah, and I think yeah, quick kind of case just to highlight the point that that undifferentiated syncope where the data isn't really adding up, you can't clearly diagnose that person. You can't put those puzzle pieces together. Don't try to make them fit. We got to go looking. So there was a case of a gentleman who was having vague headaches in the morning, evenings, no history of headaches, older male. Had a syncopal event, went to the emerge. They're like, we don't really know. You had a recent viral illness, maybe chalked it up to just general feeling unwell. They did do a CT of his head though. Plain CT was normal. Not too long after that, headaches were getting worse, had another syncope event, went to the emerge, ended up getting a CT with contrast because of the headache. Any guesses of what they found on the CT imaging, Alan?
There's too much contrast upstairs. Is that what they found?
It was a glioma.
Oh,
Yeah, so brain tumor
yes.
that was missed with the plain CT, but then with the
Yeah,
contrast highlighted the glioma. So again, just, mild vague headaches that wasn't like the focal point, but was just having these random syncopal events.
yeah,
So again, it's a really hard diagnosis to nail down. So I think yeah, using our heuristics and diagnostic reasoning to make the data make sense, right?
yeah.
Super helpful. Yeah, I mean, I threw some things. I think given time, let's just jump right into Vertigo because this is another one where I personally find challenging because patients find it challenging to describe what they're experiencing, right? Vertigo is like that sixth sense. Is it dizziness? Is it lightheadedness? Is it pre-syncopal? So for this case, to run through again, an older gentleman with continuous dizziness, nausea, vomiting, and unsteady for the last 2 days, so 48 hours. No recent trauma, no focal neurological symptoms like slurred speech, weakness, etc., and no significant past medical history. I'm sure you see these a lot in the emerge because they are miserable. So, how do we organize our diagnostic approach again to not miss badness or to not miss even those more subtle, insidious presentations?
Yeah, Vertigo. Yeah, or Weak and Dizzy. That was my favorite. And the thing is, Vertigo is going to be everywhere, no matter where you are. Family medicine, emerge, internal medicine, and it's just such a PITA, a pain in the derriere. When I see this a case of vertigo, the first thing I want to do is like, is this actually vertigo? And you alluded to the fact that most patients aren't able to distinguish the difference between lightheadedness or like room spinning. So I was very surprised to hear that the data supporting that history taking is not very good. So how I approach this is similar to my approach with syncope is I think of badness. So specific to this case here, to give us a bit of context, when I see a 50-year-old with continuous dizziness and unsteady gait for 2 days, I'm already like, when I hear that, I bet everyone's thinking, oh, it's probably BPPV. That's a diagnosis of exclusion in this circumstance. 2 days is too long. I'm going to be looking for the badness in the cerebellum, upstairs. All the other stuff like vestibular migraines, Meniere's, those are going to be diagnoses of exclusion. So in this case, with respect to the emerge approach, is rule out badness.
And I think, okay, sorry to tie in more diagnostic reasoning principles, but that classic problem representation of older gentlemen, continuous dizziness for longer than 12 hours really just triggers those illness scripts like cerebellar strokes or tumors, et cetera, right? So it's just, again, lots of exposure, reading around our cases and cementing that knowledge. So it's easier the next time we see patients, right?
Mhm.
So yeah, we're very much on the same page. I think I was listening to an excellent Curbsiders podcast a few years ago now on approach to vertigo. And one approach that really stood out to me was instead of focusing on the patient's reports, because they're going to struggle, but if they're weak, dizzy, lightheaded, it all kind of means the same thing in a matter of speaking. So
Mhm.
instead, focusing on duration of those symptoms, right? Is it triggered or episodic? More likely benign. Is it continuous, lasting longer than 12 hours? We need to rule out stroke. And then if it's lasting longer than 30 days, is it someone recovering from an acute vestibular syndrome, or is it something more insidious like MS, Parkinson disease, a vestibular schwannoma, etc.? So I
Mhm.
populated this table. It's fairly wordy, but I think it's again just highlighting if you're going to take anything from the history, because it can be difficult to gather a history from these presentations, is try to nail down with your patient, are they short-lived? Are they lasting seconds? And do they disappear when you stay still? If that's the case and they're triggered by head positions or postural shifts, we're more likely to go with that BPPV sort of differential. But then again, if it's not triggered and they're still episodic, then we do have to think about TIA, right? If they're not being triggered
Mhm.
by head positions, Dix-Hallpike is negative, we can't just slap a BPPV on there. We have to think, do they have TIA risk factors, etc. And then I think, the tricky ones are the acute vestibular syndromes, that it's continuous, it's lasting longer than 12 hours. Basically, the two big buckets I think of is this an acute, vestibular neuritis or labyrinthitis if they have hearing loss? Or is this a cerebellar stroke, right? And then we
Yeah.
already alluded to the chronic vestibular syndromes. If they're insidious and getting worse and we can't really label them with a diagnosis, then we need to look up more of those primary neurologic disorders or the vestibular schwannomas, which are fairly rare. Anything to add to that, Alan?
Yeah, it's that middle range. It's that 12 hours, few hours. And that cerebellar stroke is so, so tricky. I'm sure we'll probably talk about physical exam, and that's kind of like my
Yeah.
soapbox, but so I'll hold on to that for a sec.
Really excited because this is probably the one presentation where you're going to focus more on your physical exam versus imaging. Physical exam has a stronger, post-test probability or likelihood ratio to compare with MR, for example. But then
Mhm.
again, I'm throwing other things in the mix, right? People can present with acute coronary syndrome where they just feel weak or dizzy. So thinking about your risk factors, doing that comprehensive history. And then, Alan, I just want to plug, have you heard of mal de débarquement syndrome?
No, but
Yeah.
I love the sound of it. I love the name.
I had to practice the pronunciation, but I did. So this was a new condition that I learned about a few months ago. I had a new patient rostered to the clinic, and they said they take benzos. I was like, oh, why do you take benzos? When I get dizzy. I'm thinking this doesn't make sense. Who in their right mind prescribed benzos for dizziness, right? Could make you more dizzy. But then they didn't really know what their diagnosis was, or they had forgotten. So from the chart review, they had a diagnosis of mal de débarquement syndrome, which is a purely clinical diagnosis. It's a rare vestibular syndrome, commonly affecting females in their 40s, where they're going to report like a bobbing or swaying motion, but only when they disembark from passive motion. So trains, planes, buses, cars, and that
Oh,
persistent bobbing, swaying motion presents within 48 hours and then lasts longer than 48 hours. And the primary treatment is benzos. So I found that fascinating and just wanted to share.
oh wow.
Yeah, bobbing and swaying though, that's like the
Yeah.
kind of like being on those.
That's a very like characteristics. You can like,
Mhm.
yeah, totally.
Exactly. Yeah, just thought I'd share. It was neat. So yeah, H&P pearls, again, just kind of timing, triggers, and then targeted exam. Let's get into that because I often, again, sort of wordy, but if you could just go on your soapbox about how important the physical exam is and that it's okay to look up videos if, we're rusty on these things.
You ever watch Glaucomflecken's like videos?
No.
Oh, yeah, anyway, for those of you that haven't seen Dr. Glaucomflecken's videos on like just medicine in general, they're quite funny. He plays this one character sometimes that's like a neurologist, and then he'll be like talking to like another like clinician or whatever, and then he'll be like the other provider or clinician will be like, "Oh, I did a physical exam and I think it's this." And then he'd say as the neurologist, do you even know how to do a physical exam? Because, anyway, because, as neurologists will always say the diagnosis is in the physical exam. So I always just chuckle about that. But I mean, I think you nailed it on the head. If you ain't gonna do it every day, use it or lose it, baby. And there's nothing wrong with using your resources. And I think you've really described them well here with your physical exam here. I just want to really talk about, for a moment, I just want to talk about the HINTS exam because it's quite controversial. I'm going to tell you right now, yes, the HINTS is a great test for to rule in a central cause for vertigo. Um, However, there are multiple validation studies that show that experienced clinicians performing the HINTS exam have varying degrees of interreliability with those that don't often perform it. So, in a nutshell, what it means is if you're not doing the HINTS exam regularly and if you weren't trained to do it systematically, it's probably not as accurate as you think it is. So the reason why I bring that up is the American College of Emergency Physicians, ASAP, came out with a new guideline, I know. A new guideline in, I believe it was 2023. It was their Grace 4 guideline or Grace 3, can't remember, on the approach to vertigo. And they actually said, yes, emergency for among emergency physicians for emergency patients presenting with vertigo, you should perform the hints. There was a follow-up to that in the Emergency Medicine Journal, or maybe it was Journal of Emergency Medicine, can't remember which one. But they said that, maybe instead of relying on the hints to help you, you should really be taking all of the exam into context and just using a structured approach. And you should be practicing your full neuro exam, that's like DTRs and so forth, regularly to maintain that skill. So where does that leave us here? It's that, if you watch a couple of videos on hints, the evidence says you're probably not as good as you think. However, use it or lose it. However, we know that that's probably one of our single best tools in the physical exam. Where does that leave us? Personally, I'm the world's most okayest guy. I probably need to do the hints more often.
I 100% agree with you. And I think it's just, with these vertigo presentations, it's not like we're doing every single test listed here. So if it's a triggered episodic, yes, Dix
Mhm.
Hallpike, and then with the epi is makes perfect sense. But if it's an acute vestibular syndrome lasting longer than 12 hours, and we're trying to tease out a cerebellar stroke
Yeah.
versus vestibular neuritis, then the head impulse test makes sense. We're not going to be doing the Dix Hallpike. So really understanding what are my differentials, what physical exams will help with my further pretest probability is really helpful, and as opposed to doing that shotgun physical exam, right? And what kind of trips me up always with the head impulse test is that our patient here presenting with continuous vertigo longer than 12 hours, we definitely want to do that head impulse test. Highly recommend Googling if you haven't. But if their eyes remained fixed on the target, um, that's actually it's abnormal if the eyes are dragged off, sorry, and then they come back with that saccade, then that's a reassuring finding. So if the test is abnormal, it's reassuring. But if it's normal, then it's not reassuring because it could be a sign of stroke. But then there's always that risk, Alan, of inter-rater reliability and do I even trust the results of this physical exam, which I grapple with any neuro exam, right? So practice, practice, practice. And if you can grab a colleague randomly, right? An experienced colleague in neuro, et cetera, just, hey, can you just watch me do this physical exam and just give it to me straight, right? Can be really, really helpful. Because after we graduate, we don't always have that preceptor, giving us those strategies and tips. So that's helpful. So again, back to the case, kind of rounding things off. It's an acute vestibular syndrome because it's lasting longer than 12 hours. So already we're thinking, less likely BPPV or vestibular migraines, etc. No recent history of a URTI. Again, those must not miss diagnoses are, again, less likely acute coronary syndrome. Let's say we've sort of ruled that out, but a cerebellar stroke, right? And, that's where we're doing our targeted physical exam, the neuro exam, the HINTS exam. There's been, nystagmus noted. It's a normal head impulse test, which is abnormal in this case. Test of skew, so that's where you cover each eye and see if they're going to be drifting off in different vertical directions. That's also abnormal. But then the rest of the neuro exam is surprisingly normal. So that's another point I wanted to bring up because many cerebellar strokes will not present as that prototypical focal neurological deficits. They may not have ataxia. They may not have those classic signs that we're looking for. So even with this information alone, an older gentleman, I can't guarantee this is just a benign acute vestibular neuritis. We need to go searching for stroke. So diagnostic imaging, Alan. So that's another big tip I wanted to bring up tonight because I was surprised in looking at the stats of how poor imaging can be, especially in that first 72 hours. Um, so any kind of thoughts on that to start? I'll just pull up these stats here.
Yeah, the donut of truth, the CT scan. It's actually kind of sucks for posterior strokes. MRs, they're great if you can get one, and they might miss early strokes. So it really goes based off your pretest probability of your his H&P.
Yeah. Yeah, CT, horrible for cerebellar strokes. They are tiny strokes, right? It's not like
Mhm.
we're looking for a massive stroke in the bigger vessels here, running a CT angio protocol where that would be appropriate. But those cerebellar strokes notoriously missed with CT, and even MRs have significant limitation in that first, 72 hours. They can miss those cerebellar strokes. So kind of going back to that diagnostic reasoning principle of just because it's negative doesn't mean it hasn't been ruled out. And this is where I think a lot of studies will say that cerebellar infarctions are commonly missed because of a lot of factors, the absence of classic neuroscience, and then a clinician's they're less reliant on the clinical signs and their physical exam, right? We may rely too heavily on that diagnostic imaging result to say, oh, this patient's fine, let's send them home. So again, just being aware of some of those cognitive biases that can get in the way of this diagnosis. Super helpful. Some major takeaways from this presentation that you want to send folks home with.
It all boils down to, at least for me, is really knowing what that trigger is. The answer, what did what's his pickle say? Who's that one Canadian physician that Osler? What did Osler say? Listen, bit of an antiquated quote, so I'll just modernize it a bit. It's like, listen to the patient. They're giving you the diagnosis.
Mhm.
The money's in the history, especially the trigger. And the timing and the chronicity. So that's by far the biggest one. Second one is, as much as I love the donut of truth, it's probably not as true as I like it to be. And the third one is, I don't have any data for this, Vicky, but I can just tell you is that the amount of times I've seen cerebellar strokes in young people
Yes.
is too many.
Yes.
So when there are non-specific kind of, the general saying is that, with broad strokes, the more severe your vertigo symptoms are, it's probably peripheral.
Mhm.
The more subtle the symptoms they are, it's more likely to be central, although there is
Mhm.
overlap.
Yep.
So when I kind of get that, like everything's kind of coming up normal, but there's just enough of the story where in a young, healthy person, I can't just say, it's probably peripheral in etiology, send you home, then I
Mhm.
will go looking for a posterior stroke. Another little heuristic that I have, Vicky, is like these days I don't drive as much anymore. I walk to work and stuff. So I say is if I'm thinking about the case when I'm walking home, I need to go back and fix it.
Yes.
I don't like to think about cases anymore. So I
Same.
usually, and so far it hasn't burned me yet. So I use that as a little bit of a personal mantra.
I love that. And it's true, like cerebellar strokes are missed because we think, oh, there's no vascular risk factors here. They're young, they're healthy, but they do happen in healthy folks as well.
Yeah.
Um, Listen, Alan, we have 4 or 5 minutes left. Do you think we can rip through Abscess real quick?
Yeah, it's super
Okay.
easy.
I
It's
know, right?
POCUS.
There's some fun things and kind of new antibiotic guidelines I wanted to go through. So, person comes in with a painful lump. What's our approach? I'm just going to run through some things here. Basically, is it infectious or non-infectious, right? Whether it's an abscess or an infected cyst, like a dermoid cyst, etc. Some non-infectious etiologies, we may think, results, side effects after a steroid injection, AV malformations. If they're having recurrent cysts or abscesses, think of hidradenitis suppurativa, commonly missed, especially when seen by different providers. Maybe it's lymphadenopathy or something else. So let's say this is bang on the point, feeling and looking and sounding like an abscess. There's no risk factors in this person. It's been bad luck. Um, when would you refer, like more serious cases? And is there a role for POCUS?
What would I refer is based off the risk factors. If they're an immunocompromised, weirdly EHS, they're all sorts of like immunosuppressants. I don't like them. Go away, go away. But what I want to focus on is like POCUS. So can I show you some more pictures?
Please, yes, I'll stop sharing.
In this screen here, you'll see here this little kind of the near field of the screen. That's kind of like the dermis, that's the epidermis in the up here. This is muscle and that's bone. That's what it should look like when you pop a POCUS onto soft tissue. This is what it would look like with cellulitis. So this would be like, I was kind of like rapidly pulling these images up as you were talking, Vicky.
Love it. Appreciate it.
This cobblestoning is this is in the superficial tissues. Notice how it looks different than up here,
Mhm.
right? So that's very, it's almost kind of like smooth looking.
Very
This is
smooth.
very cobblestony. That's very hallmarky of cellulitis. You can probably appreciate a little bit better here. The reason why it looks like that is because if it's red, inflamed, and angry, you got that vasodilation and the capillary leak. So all that interstitial fluid manifests as these black little bits amongst the tissue. So the tissue is this white stuff, gray stuff, and the fluid leak is all that black stuff. Now, and the next logical question is, if it's cellulitis, is there an abscess? I mean, you could do an ultrasound, you do your physical exam. Sorry, you can send them for a formal ultrasound and maybe get it in the next 48 hours. You can use your physical exam, maybe flip a coin, or you can just put POCUS on. This is generated off a butterfly probe, but this you can see the cobblestoning of the superficial tissues here, and then deep to it is this kind of big black space here. And you know how see how it's kind of like well circumscribed, like really well defined. That's a big old pocket of fluid, so it's likely all pus. So if it's deep to that, that's most likely in keeping with an abscess cellulitis.
AV malformations can mimic cellulitis sometimes. You
Yes.
never want to poke an AV malformation. Or maybe you're worried about the location, right? If it's under an armpit, we want to be sure it's an abscess before we go draining those areas. And then personally, I avoid the face and I avoid the hands. I think other people should be handling those abscesses
Yeah.
outside of my primary care clinic.
Oh,
So
and I should add with POCUS, you can add color to the image. And if you can see color, then it's probably vascular. Abscesses
Ooh.
should not be vascular. So you can rapidly exclude blood flow to it.
Another role for POCUS. I'm so jealous. And
I'm
I
not
think
sponsored, although I'm open to it.
I think you've convinced me. So yeah, kind of rapid fire steps for IND because that is the treatment for abscess. So we don't necessarily have to prescribe antibiotics unless there is concurrent cellulitis. So we always review those common risks with patients: bleeding, pain, risk for recurrence, scarring, etc. Don't make the mistake I made in forgetting PPE one time. I've never never not remembered since that. Clean, clean, clean. Question for you. Do you anesthetize or not? Because I've seen two rules of thumb. People will poke with a number 11 scalpel, let it drain. But then I'm of one that I anesthetize because it's going to be a long procedure. I'm going to be poking, prodding, breaking up those loculations. I just want to provide some pain relief for patients, but I've seen both. So what's your approach?
I try to. It's hard to anesthetize infected tissue. I try my best.
Yeah, on the same page for that. Um, just, highlighting, making sure that you drain everything out. You're probing, you're looking for tunneling. Is it deeper than we initially thought? Breaking up those loculations, because if we don't get it all out, it's more likely to recur. To pack or not to pack? Again, I think the jury's still out on this, Alan. What's been your kind of experience and practices in the emerge for packing or not to pack these abscesses?
Well, assuming this is like let's just go and assume that this patient has a large abscess. I want to show you something like you probably all know about IND and packing and stuff, and the decision is really based clinically on the patient in front of you. But if it's a big abscess, can I show you something that will change your practice? Can you see this lemon,
Yep.
Vicky?
Mhm.
So this is called the incision and loop drainage of an abscess. So imagine here that this lemon here is the abscess. So instead of just doing like a wide incision and just draining it that way, especially for these that you want them to kind of drain and leak, what you can do is incise at the borders of the abscess and pass a surgical tie through. You do a surgeon's knot, tie it up, send them home. What that does is that, and you can even tell them periodically, they can rub on the surgical tie to help promote drainage of the abscess. It scars better, it's less painful, and it's super easy to remove because you don't need a ton of resources to take the packing out and so forth. You just send them to any clinic or any nurse and they just take it out, and they're happy. Works for kids, works for adults, change is a game changer. So this is called the incision and loop drainage of abscesses. I swear I didn't make this up. This is from Pete's EM morsels. There was a paper published in, I think it was GEM. I can't remember, but it is published. If you just Google it, it's out there. I would say for anywhere between if it's the abscess that you want to continue to leak and you're not sure if you know, they need follow-up is questionable, that type of thing. I find that this is probably best for anywhere between like halfway between small abscess and medium abscess to like medium but not medium large abscess. If that
Sure.
makes
Well,
sense.
that's amazing. Thank you for sharing that. I'm gonna ask for that reference later. Tetanus booster, I'll say, practice out here. If they haven't had one within 5 years, you probably want to give them a tetanus to be on the side of caution. I see most people perform culture and sensitivity swabs, even if there's no associated cellulitis. So, what's your take on that? Should we be doing CNSs or no?
I think that it would only change my management if I was truly looking for MRSA, if it was recurrent, or if it was complicated. Otherwise, it's probably not going to give me too much info.
Love that because we want to drain it. We want to send them home if we're not giving them antibiotics. It's an uncomplicated case, then the test isn't going to change our management. So going back to those principles. And then for antibiotics, right? Unless there is that associated clear cellulitis, so 3 to 5 centimeters of spreading erythema, pain, not just localized around the abscess, because that's going to be red and painful, but if they're that classic characteristic cellulitis, if you have POCUS and you can see the cellulitis even better, PO, I would say more and more evidence, 2024, 2025, short course, short course, short course for these uncomplicated mild cases, right? 5 days versus 7, 10, 14, which is really old practice. And then IV, of course, if they're systemically unwell, you're running blood cultures on them, they're probably sticking around your ED for longer. And Alan, I was curious because I was looking up some emerged practices from 2024 in Canada, but what are your thoughts on prescribing NSAIDs specifically for cellulitis associated with abscesses? Because apparently it can reduce inflammation and promote healing if there's no contraindications. That was new to me.
Yeah, that was new to me too. I haven't critically appraised the primary articles. I think I saw like a systematic review, but it was like only a couple of, maybe it was like a few hundred patients or something. So I don't know. I think it's promising. I think also the downside of NSAIDs is pretty low. I mean, frankly, I'm a bit biased. When anyone comes sees me, I just give them, Voltaren gel, Toradol, an SGLT2, just because they all work. Maybe some Ozempic too, because it just works for everything.
Yeah, yeah, yeah. Appreciate that. Yeah, so short course, 3 to 5 days if they're again reduces pain, improves healing for the cellulitis though, not just the abscess. So couple random take home points. So CNS only if it's going to change your management, if it's a complex case, immune compromised, recurrent abscesses, complicated cellulitis, we're worried about MRSA. Goes on that thread too. Antibiotics only if there's that extensive cellulitis, immune compromised, systemically unwell. And then shorter courses is better. That's what all the data is telling us now for mild, uncomplicated cases, for sinusitis, for cellulitis, for many diseases across the spectrum now. And then just another quick pearl, always educating your patients if they have that abscess associated with cellulitis. Their clinical improvement only really happens around that 72-hour mark. So that natural course of cellulitis, they're going to have some more swelling, redness, maybe even a bit of pain. It doesn't mean that things aren't improving. It's just that natural course of cellulitis.
Mhm.
So 7 minutes over time, but any kind of other random take-home messages that you really want to share with people tonight, Alan? It's been a lot of fun.
Thanks for having me. And I think we covered a lot. I think the big one though is that point of care ultrasound is not scary. You also do not need to be like a super brilliant human being like Ross Prager, although he is. Don't get me wrong. Anyone can learn POCUS. Anyone can learn POCUS. It is learning a skill like your physical exam. It does not replace any testing, but boy, does it enhance your physical exam and your rapid decision making. Um, it's not as scary as it thinks, and the magic number is 50. For some reason, is if you do a view with a point of care ultrasound 50 times, it clicks. Okay, Vicky, I know I'm not, I swear I'm not like some ivory tower nursing prof that just says you need to do this. The ASAP Point of Care Ultrasound Society was like, yes, it's 50. And I was like, this is BS. Like, that's just a number pulled out of the air. I tell you, it was like 46 scans. And I was like, oh my God, it clicks. 48 scans for ocular. It was like 49 for gallbladder. And I was just like, oh my God, it's actually 50.
Amazing.
So, and I'm not the world's smartest human. I'm the world's most okayest, mediocre, and just better than average. So, you can learn it too. It's just practice and getting onto the horse.
Love it, Alan. And yeah, I'll reach out to you for some of those resources so I can share with all the participants and people who registered tonight. Because even me, you've sparked my interest. It's been on my to-do list, and I think it's a really powerful tool that we can all have in our belt. So thank you so much for being with us tonight.